So today is a really good day to check in with MU physician Dr. Hari Regunath. Dr. Regunath specializes in critical care, pulmonary disease, and infectious disease, and he has been working for months now on the front lines of this pandemic. Dr. Hari Regunath, thank you so much for coming to the check-in. Welcome. Dr. Regunath, are you there with me?
I am.
All
I am
right,
here.
thanks, and welcome to the check-in where we do live by remote to enhance everyone's experience here. It's really nice to have you here because that's what I was saying, Dr. Regunath. It's kind of a stressful time, but no one has the right to be more stressed out probably than you right now. So we want to hear how things are for you as spending months on the front line. Let me just start with the general question: how are you and the hospital right now managing day to day?
Well, we're relatively doing well.
Okay.
Our caseloads in the hospital have been pretty steady
Mm-hmm.
in the medical ICU as well as outside of the ICU, where we admit to the designated areas where we admit COVID-19 patients. So we have been relatively doing well overall.
Okay, so that's great to hear. And it looks like you've had a handful, maybe six, I think, a couple of days ago, hospitalizations in Boone County. So that seems manageable to you. Let me just, before I get off from because I'd really love to dig in a little bit with you, Dr. Regunath, with the science and what we know about the virus so far. But before I leave the hospital front and the front lines front, is there anything that you're concerned about? What is kind of your focus? Is there anything keeping you up at night when it comes to the hospital and the ICU and our treatment right now?
Not really, because in the beginning, a lot of uncertainties about the supplies on the PPE, personal
Hmm.
protective equipment.
Hmm.
And we have seen since March and April to now, through the different phases of the command center activation that we've seen, we've had a steady supply. We've been really stringent and careful in documenting how many PPEs we've been using and appropriately using them, more for the attending physicians and limiting the use by the learners. So we have certain strategies in place that have kept us within a steady supply of PPEs. We never were crunched on the numbers on the PPE. That's number one. Number
Good.
two, in regards to beds allocation for these patients, we have a segment that's within the ICU and another segment that's outside of the ICU. And never so far with our clinical management and our research management, we really never outrun our the demand. So we're doing relatively well. So
Uh,
nothing really concerns me at
That's
this time.
great to hear. And I painted kind of a dismal picture in the intro just now, because cases seem to be on the rise, but hospitalizations are steady for us. To what do you attribute that? Is it an increase in testing?
Most likely, the more and more wide availability, as well as probably because it's open now, there is more and more gatherings. So we are probably seeing more transmission as well, which is not surprising. And we hoped that there might be some seasonal variation, but apparently not. And we are learning that as time goes by.
Hmm. All right. As someone who's treating these patients right there in the ICU, what would you say are some key things that we are learning about the virus at this point? And let me just mention something that's been in the news even yesterday, I believe, or 2 days ago, the University of Florida study that is early, but yet seems to have collected aerosols from the virus at a distance of maybe up to 16 feet in a hospital. What do you think of that study? Is this making us rethink how the virus spreads in indoor spaces? And what generally are we learning that stands out to you?
Absolutely. So the droplet spread and fomites were thought to be one of the important ways how the virus is spread. Aerosol was in question because probably the ways they collected air samples wasn't tuned enough to isolate the virus particles as much as the University of Florida study did. They
Hmm.
used a type of a particular equipment that was able to have condensed air along with water, which is normally happens when we all breathe. Our mucosa moistens and humidifies the air. So considered to be more simulating the infective viral particles. So this is the first evidence that came out more in support of aerosol generation. But I feel reassured because we've been using our PPE stringently in our ICU, and we've cared for so many patients so far. Total in-hospital patients, I think we are across 100 now at MU, a rough number. And within the ICU, I've cared for almost 40 patients.
Hmm.
And none of us have contracted or known to be positive. Some of us might have developed mild symptoms, but really we didn't get affected as direct frontline healthcare providers. That speaks to the strength of stringently following the PPE requirements, and that keeps us safe. So, this is adding to the evidence saying that closed spaces are not good, and gatherings within closed spaces are probably something that we should avoid in this situation. So, there's more and more strength to that because the places where they sampled it were in the patient's room who had active disease. Out, when you have good ventilation, then you have to factor in how many exchanges are happening. The study, when the setting in which they did, those rooms had, they were not full negative pressure rooms. They were 6 exchanges per hour, which is half of what a full negative pressure rooms are, which is how we also manage patients in the ICU once they are intubated because their airway and airlines are covered and controlled in a more controlled environment. So there is a message, there is a learning point from the study, but how does it ramify in the future in regards to the guidelines from the CDC and WHO? We'll have to wait and see. We have to see
Yes.
more and more consistently what more evidence comes up.
Okay, so I hear what you're saying. So that is sort of inductive evidence, sort of from that study. But again, when we say it was seems to have been collected, within 16 feet, it still
Right.
doesn't really say what the impact is, does it, on individuals? So there's no reason to panic any more than we already are necessarily. But
No.
Dr. Regunath, I have to say, when you say that you've looked after 40 patients, you haven't seemed to contract anything. I just can't tell you how wonderful that is to hear at this point
Touch wood.
from you. Let me just remind our listeners, this is the check-in. We're talking with MU physician Dr. Hari Regunath. We're talking about his work on the front lines of healthcare during this pandemic, caretaking our COVID patients here in Boone County, what we have learned about the virus, treatments, and the way forward. Dr. Regunath, what about treatments? You are, as you say, looking after, dozens of patients, not at one time, but over the last few weeks. And I imagine the protocols for how you're treating COVID-19 as a physician is changing, and it's changing at a time when there are research studies and information coming at you all the time. How do you balance all the research and the information with your protocols in the actual ICU?
So it's primarily severe pneumonia or
Hmm.
acute respiratory distress syndrome or ARDS, requiring patients to be on the ventilator. In the early part of the pandemic, we didn't have any evidence towards any particular drug having an effect. Now we have at least 2 or 3 options that are at least proven to be safe and show some benefit in terms of mortality and the time to discharge or the speed at which they recover. Number one is an antiviral drug, remdesivir.
Hmm.
Number two is a steroid, which is dexamethasone. And number three is plasma. And primarily, these are the 3 options that we use in our hospital. Plasma is available as still as a part of a clinical trial via its FDA regulated clinical trial with the Mayo Clinic lead. We are a participating site and we offer them as early as possible. How soon do we give them? The earlier, the better. Right now, these treatments are reserved for hospitalized patients who require oxygen. Um, we don't, the antiviral drug is only IV, so we won't be able to give it to anybody, and it's not recommended to be given to anybody with milder symptoms who is being discharged home. So we have certain criteria as a part of protocol in our hospital. A few options available. Prior to this, majority of our treatment approaches were related to supportive care to just wait it out until body develops immunity. And once our patients get intubated, some of our patients, a third of our patients, recover within 2 weeks. A third take up to 3 to 4 weeks, and another third of patients go longer. They have more comorbidities. It takes sometimes 6 weeks, 7 weeks, requiring tracheostomy and prolonged weaning from the ventilator.
Have you been able, Dr. Regunath, to see those numbers improving over the last few weeks? It's really been a very short time, but as you said, these three main frontline treatments that you are able to work with, are they improving the outcomes for your patients?
Well, I would say it depends on the immunological biotype and phenotype of the particular patient and how deranged his body systems are. So, severity of illness at the time of presentation determines their outcome more so. Um, so far, the trials are the only go-to place for me to say there is benefit. In our patients, the rate of recovery has been steady and the same at any given point in time. If there are markers of very severe disease, those patients some don't make it. And this we see it even in influenza and other respiratory viruses. So for us, we are seeing a larger proportion of COVID-19 patients who get admitted develop more severe respiratory disease.
Hmm.
Um, we kind of see a similar picture for influenza, but the severity in COVID-19 seems to be higher. The rate of everybody who gets hospitalized have more severe disease as against influenza. We don't see that unless the strains are virulent on a year-by-year basis. We don't see it consistently.
All
This has
right.
just this has just started, so
Yeah,
we will
well,
learn
and
more.
that's part of the tragedy of this pandemic that we're in, I think. And you, Dr. Regunath, are kind of, as I was just saying, having to balance the research and the studies that go on with your frontline, care to these patients. There was an article in the New York Times, which may or may not apply to you, but it was about how some frontline physicians are getting some pushback or having to balance the needs of data for patients that are in clinical trials to do things a certain way that kind of sometimes go against their gut instincts on what the patient is needing in the moment. Does this apply to you all here in Boone County, where you're having to address that balance as you look after patients?
Right. Clinical trials are conducted in a very controlled settings, and if we
Mhm.
don't satisfy the criteria, it becomes really hard for that statistical model to interpret the results.
Yes.
So that's why it's important to hold on to what they are. What It's always in the hands of the treating clinician. If
Mm.
he decides that this patient on a particular clinical trial would benefit from changing the approach a little bit, then that patient will be excluded from the trial. That is generally how we approach treatment for our patients. Our patients come first, no matter even if they are in the clinical trial. The only trial that we are doing right now is in convalescent plasma.
Yes.
Fortunately, remdesivir is supplied by the state, and we have enough supplies for our patients so
Great.
far with the load that we have. The plasma is a relatively safe therapy and really not a lot of stringent rules for that, so we are able to conveniently provide it. We never had those dilemmas on this particular treatment will exclude them from receiving other treatments. No, not really. Yeah.
Okay, great. That's good to hear. Dr. Regunath, let's talk a little bit about vaccines. That's also been in the news this week with Russian vaccines in the
Right.
news. Where do the vaccine trials here in the U.S. Stand from your point of view? And given what we know at this point, how optimistic are you that there will be a safe and effective vaccine available, as Dr. Fauci said, possibly in the first few months of next year? What do you
Right.
think?
Right. Well, in the history of infectious diseases and pandemics, this is the fastest rate at which a vaccine has been developed. It's mainly because of the technology that they have. They're able to generate it in the lab. These are called mRNA viruses, messenger RNA virus, mRNA vaccines, not viruses. These vaccines have the genetic material essential to code the protein that is responsible for virus attachment to human cells, and they simulate just the production of the protein by giving them through a genetic material that's absorbed by human cells, and they produce these proteins simulating the virus, and body generates immunity. So we are entering phase 3 trials, which means we're trying it in larger human populations to see how safe it is, what doses are more safe and what doses are less safe. Really, what it is testing is to see if you're generating antibodies. Um, So the antibody responses seem to be good so far, but really, when it comes to how far is it going to protect you from natural infection, depends on giving it more time to see with natural, when they come across a natural environment where they're exposed to the virus, whether it will confer protection or not, and how long the immunity lasts. That is a test of time. So
Mm.
even by this winter, if we have this phase 3 trial, some preliminary results, because we have started it now, I'm seeing in the news and everywhere that in last week of July and first week of August, we've moved on to phase 3 with the Moderna vaccine. And if those results are available even by November, December, only by waiting more time, we will know if they are sustainable responses. The lab research related response does not essentially correlate into protection for the entire population. The behavior will be known only by giving it time and allowing it to pass through the natural exposures.
All right. Dr. Hari Regunath, thank you so much for joining us. Only time will tell, as you say. We
Right.
hope you'll come back and join us on the check-in again. In the meantime, thanks for all you do. Please stay safe and take care.
Thank you for having me. Bye
Yeah, it's
bye.
a pleasure. Bye-bye.